Now we are go to live, sir. Start.
Hello and good evening, everyone. We are now for the sixth in the series of clinical cardiology class, the Young 3C of Budding Cardiologists, where we do clinical case presentation and discussion. Today, I have two eminent faculties, and we are discussing important case along with myself and Dr. Jaymajan. We have Dr. Ashwini Kumar from Delhi and Dr. H. Srinivas, who will be taking us through in this clinical case presentation on young CAD. And we have, it's glad to have Dr. Abhinav, a former student of mine, who's presenting the case of young CAD. So, welcome, Dr. Srinivas, and welcome, Dr. Ashwini Kumar.
Thank you.
So, Dr. Abhinav, can you share your slides and screen set, your slide deck for the
Yes,
case
sir.
presentation of young CAD?
Yes, sir, I'll do that.
Dr. Ajay Majan, sir, is also there. Sir, Majan, sir, good evening. As you all know, Dr. Majan is professor and head of the department KEM Hospital, Mumbai. Sir?
Good evening. It is very important topic today, that is young coronary artery disease. Now, after passing, everybody has to work on these particular cases very frequently. The most important thing is that when we are discussing this particular topic today, this is the uniqueness of this particular program, because all other programs are in most of the time in exams, this particular thing is not discussed. But in day-to-day practice, this is every day's discussion. So we must know what to be what specific things to be seen in patients with a young acute coronary syndrome. So today it is one of the most important topic for practical life.
Right, sir. So as you mentioned, this is now actually being taken up very strongly by DNB. Most of the DNB exams actually have a case of CAD, young CAD, or heart failure, young heart failure. A lot of exam centers and universities, including ours, have started taking this as a short case. So we thought that this is the uniqueness, as sir was mentioning. No other center, no study program takes this. This is the one that everybody practices, and it's important that should be part of the curriculum as well as practice. So over to you, Dr. Abhinav. You can start your case presentation as our experts, Dr. K. Srinivas and Dr. Ashwini Mehta sir are with us as the expert examiners, apart from myself and Dr. Majan. Over to you, Dr. Abhinav.
Thank you, sir. Good evening to all respected teachers. So I'll be presenting a case of a young ACS in a young male. So our patient was a 29-year-old gentleman who was an advocate by profession, and he was also a competitive athlete. So he used to participate in weightlifting as a layer, not as a profession per se, and he was a resident of New Delhi. He presented to the emergency department of Safdarjung Hospital with chief complaint of sudden onset severe retrosternal chest pain associated with diaphoresis around 12 hours ago prior to presentation to our hospital. He was apparently well 12 hours ago when he developed severe retrosternal chest pain while he was eating food, which was sudden in onset, severe in intensity, radiating to the neck and to the left arm, and it was associated with diaphoresis and palpitation and a feeling of impending doom. The patient described the characteristic of the pain as a feeling of squeezing or crushing of the chest, and he said that he had never felt this kind of pain ever before in his life, and the pain lasted for around 60 minutes. When his symptoms began, he visited a nearby hospital for his symptoms, where his electrocardiogram was done along with some blood tests, according to him. And he was given multiple oral tablets to chew along with a sublingual tablet, after which his symptoms improved to a certain extent. He was then referred, since he had visited a primary healthcare center initially, where his initial ECG and blood tests were done. He was then referred to our center for further management to a cardiology subspecialty. And by the time he came to us, he was pain-free when he visited our center. On further probing and taking a detailed history, since he was a a competitive athlete and a weightlifter. So we were looking for a cause, and on further probing, he admitted to the use of a drug known as clenbuterol, which he used to occasionally take for bodybuilding for the past 3 months on the advice of his gym trainer. And he used to occasionally take 3 tablets of 40 micrograms each for the past 3 months. However, he had increased the dose to 180 microgram, and he had himself taken 4 tablets of the drug 45 minutes prior to the episode of chest pain, diaphoresis, and palpitations. There was no history of hypertension, diabetes, or smoking. He had never been tested before and had never visited any healthcare facility for routine screening before. There was no family history of heart disease or sudden cardiac death in his family. There was no history of any other recreational drug abuse apart from the use of the drug clenbuterol for bodybuilding. And there was no history of any exertional chest pain or any shortness of breath on exertion in the past. No history of any limb weakness, altered sensorium, or slurring of speech in the past. No history of any intermittent claudication in the past. And there was no history of any headache, of migraine, or intermittent bluish discoloration of limbs in the past. And as I mentioned before, he had never visited a hospital or any screening facility before, and there was no history of any major medical or surgical illness requiring hospitalization or visit to a doctor in the past. And he was a non-alcoholic, non-smoker, had non-vegetarian diet, and had normal appetite and normal bowel bladder and sleep habits. And there was no significant family history, and he belonged to lower middle class according to the modified Kutuswamy scale for socioeconomic status. On examination, the patient was conscious, cooperative, and well.
One second, Abhinav. So let's go back to your history in the sense. So, what kind of angina do you think this patient is? It a classical angina that you're dealing with here?
Yes, sir. As per the description given by the patient, the pain was very typical, and since it was associated with diaphoresis and it was felt as a feeling of squeezing of the chest.
So, what are the atypical manifestations of a cardiovascular pain or atypical angina?
Atypical manifestations can be, sir, nausea, sir, or vomiting, or patient may have palpitations, and dyspnea may also be there, sir.
Correct. Dyspnea, dyspepsia, giddiness. Who
Yes.
are more likely to manifest atypical symptoms?
Generally, sir, females are
Absolutely.
more
Right.
likely.
Right. What is Heberden's angina? Heberden's angina.
Forbidden angina, sir. Sorry, I don't recall.
What is Fidipides angina?
I don't know.
What is occupational angina?
When patients who work in industries which have nitrate exposure to nitrate, so those patients have angina on Sundays because that is the time when they are not exposed to nitrate. So
Skin
angina.
exposure, right. So that is correct. Occupational angina is in nitrate workers. They're especially used in
TNT.
ammunition factories.
Yes, sir, TNT.
Old ammunitions. Now they don't use that anymore, but they have more super explosives. Anyway, what is linked angina?
Linked angina.
Linked, LIN, LinkedIn type link.
I don't know.
Okay, so Heberden's angina is the classical angina that you described was first described by Heberden. That's why it's called as Heberden's angina. Fidipides angina is athlete's angina. Fidipides is supposed to be a Greek mythological warrior who ran to break the news of the Athens war that had broken out, ran more than a marathon a distance and collapsed after giving the news. That's how historically Fidipides has been associated as the one whose name is ascribed to athletes angina. Linked angina is angina with GI disorders like GERD or abdominal angina. So that's linked angina. What are the mimics of angina?
Angina mimics can be, sir, dyspepsia, nausea, vomiting, or palpitations, or excessive fatigue, or vertigo, or dizziness.
this, as Dr. Kamal said, there's a GERD related esophageal, lower esophageal sphincter spasm. Can mimic an angina, can be very well relieved by nitroglycerin
Right,
also.
right. Yeah, diffuse
These are all
esophageal
some
spasm.
mimics. Kamal has anything else to say on that?
Absolutely right. That's right. So mimics are basically biliary colic, esophageal spasm, obstructive sleep apnea, and GRD. So as Srinivas sir has clearly mentioned, those are the classical mimics. So that's the mimic. You don't, the atypical manifestation is a different question. Mimic means patient doesn't have an angina, but the pain is mimicking that of an cardiovascular pain. It's not an angina otherwise. That's what it means. Right. So what are the causes of angina with normal coronaries?
Sir, angina with normal coronaries can occur in patients with vasospastic angina or the classical Prince metal angina. It can occur due to microvascular disease known as the syndrome X, wherein
So
the
let me put it other way. Tell me causes of non-coronary etiology of angina.
non-coronary etiology of angina can occur when there is a demand-supply mismatch. For example, in patients with anemia or in patients with obstructive lesions like aortic stenosis or hypertrophic obstructive cardiomyopathy, or even in patients with right ventricular hypertrophy, for example, in patients with mitral stenosis or RVH due to any cause. So whenever there is a demand-supply mismatch, that can cause angina.
I would like to ask you a question. You said that the pain lasted for 60 minutes. So, what are the other DDs which are there in your mind? 60 minutes is quite some time. What is the typical angina's duration? What is the duration of myocardial infarction? And what are the other things you are thinking of?
So the patient's pain got relieved after he visited the health center. So any pain which is lasting for more than 20 minutes occurring at rest is more likely to be an acute coronary syndrome and either an MI or unstable angina, sir.
Right.
And so this
So,
patient,
pain got totally relieved or he got some relief?
according to him, it got totally relieved. Probably it was because of the intense sympathetic activity
Okay,
caused
right.
by the drug that he had taken. Probably that tachycardia or hypertension could have caused.
So, what can be the other possibilities other than myocardial infarction? What else can be like that? One
Considering
was,
Severe chest pain can be, sir, due to aortic dissection, sir,
yeah,
in a young male. And since he's a weightlifter, we can also think of ruptured sinus of Valsalva. RSOB can present with sudden chest pain followed by dyspnea in a young male patient who's into lifting heavy weights.
yeah.
Apart from aortic dissection, also it can be pulmonary embolism also, sir. Can present with sudden onset of severe chest pain, sir.
Yes. So, did you ask this patient anything which is suggestive of that?
Sir, for aortic dissection, sir, his history was not very typical of an aortic dissection because the pain was largely localized to the anterior chest and it was not radiating to the back or it
Right.
was
So, you must mention this. Okay. What
it will
else?
be sudden
What
in aspect. The aortic dissection pain will be sudden and severe at the
severe?
same. There is no crescendo effect and all. It will be
Yeah.
instantly very severe and stays at that and
Yeah.
less immediate.
Yeah. So it is usually non-resolving. Usually it persists, but then this can very well be aortic dissection, which can present like that, but with a few things. And what about pulmonary embolism?
the pulmonary
What
embolism.
kind of pain you get in pulmonary embolism?
Sir, the pain is due to pulmonary infection, so it is more of a localized and a sharper pain as compared to the pain of angina, which is not as well localized.
Yeah.
Right.
So what else you would ask in the patient?
Any history of, sir, for pulmonary embolism, any history of any prolonged immobilization or leg swelling in the past, or any history of hemoptysis or coughing associated with the episode, sir?
So inspirational change, always there is a pleural pain. So it is always related, on inspiration, you get on respiration, you do get little aggravation, and you might find patient leaning forward, which you might get even in dissection. So you should mention this in the history. Okay. I think we can move on.
Yeah.
Moving on to the examination. On examination, the patient was conscious, cooperative, well-oriented to time, place, and person. He's well-built and well-nourished, with a height of 168 centimeters, weight of 81.4 kgs, and a BMI of 28.8 kg per meter square. And he had a waist circumference of 103 centimeters.
Comment on that? Your comment on that?
Sir, he was, according to the Indian standards, he was in the obese category. And
Okay.
according to the Western standard, he was in the overweight category. And his waist circumference was also well above the cutoff for both Indian as well as the Western standard.
So he gets he qualifies into abdominal obesity plus overweight or obese rather.
Yes.
So how are obesity cutoffs same or different from Indian and the Caucasian counterparts?
Sir, in the Indian population, the normal BMI is still 23, and the BMI from 23 to 25 is taken as overweight, and above 25 is obese. While in the Western counterparts, normal is still 25, and 25 to 30 is taken as overweight, while above 30 it is taken as obese.
What is YY paradox?
Why paradox? I'm not aware. Sir.
So two researchers from India, two researchers, one from India, one Caucasian, for the same height, weight, BMI, when their lipid deposits are looked for the visceral fat, the percentages are strongly in the favor of having higher abdominal obesity in patients of Indian origin. So for the same BMI, you have higher visceral obesity and visceral fat, which is also a marker of insulin resistance and probably a higher risk of getting a myocardial or coronary event. So what are the traditional CV risk factors and how much attributable risk together combined they would attribute occurrence of cardiovascular event? Any study you know of?
In young patients, sir, there was a coronary artery disease in the young CADY study from
No.
India.
So one of the largest study, what are the classical 10 traditional risk factors that can explain or attribute an acute coronary event or explain the occurrence of a coronary event in patients who present with acute MI? I'm asking in general. What are the
Remaining
traditional risk factors?
the traditional risk factors would be hypertension, diabetes, smoking, dyslipidemia, obesity, and alcohol intake. And the new risk factors would be the inflammatory risk manifested by the increase in hsCRP, and the residual lipid risk as by the increased lipoproteinase.
So Interheart study explained 10
Interheart.
important risk factors which attributed 90% of the occurrence of attributable risk. Right. So the traditional 10 are hypertension, diabetes, smoker, sedentary lifestyle, obesity, family history, lack of exercise, psychosocial stress, alcohol in moderation, and of course lipids. So these together explain 90% of attributable risk in a patient. So when a patient comes with MI, these 10 can explain 90% likelihood why somebody got an MI. So amongst these risk factor, which is the most prevalent one in our part of the world amongst these 10?
Smoking, sir.
No. Smoking, what is the prevalence?
Dyslipidemia is most prevalent in Indian population as a whole,
Correct.
and smoking more prevalent in the younger patients with ACS.
Oh, yes.
Good
So,
sleeping, yeah.
correct.
So, the interestingly, Interheart study also looked at the consumption of fruits and vegetables, the number of servings. And this was something very unique, and it also had a correlation, and also psychosocial stress, which were unique in this study. So you see a young person with similar presentation. So is your examination complete, or you're looking for something else also? You are still to present. Yeah. Okay, good.
So on the general physical examination, we look for signs of atherosclerosis or increased cardiovascular risk. So there was no earlobe crease, there was no xanthal asthma around the eyes, there was no tendon or palmar xanthomas, and there was no evidence of a corneal arcus. And the other vitals were within normal limits. Pulse was 90 per minute regular, normal in force volume, and bilaterally symmetrical with no radial or radiofemoral delay. And all peripheral pulses were palpable, and there were no bruit on auscultation. The blood pressure was 148 by 88 millimeters of mercury in the right upper limb and comparable in all four limbs. And respiratory rate and the saturation in the JVP were within normal limits. Coming to the cardiovascular examination, the chest was normal, bilaterally symmetrical, and apex impulse was visible in the left fifth intercostal space, just medial to the mid-clavicular line, and there was no evidence of any other visible impulse, scar, or dilated veins. On palpation, the inspectory findings were confirmed. Apex beat was in the left fifth intercostal space, just medial to the mid-clavicular line, and it was normal tapping type, and there was no palpable heave, no thrill, rub, or palpable house sound. And on percussion, the upper border of the liver durnus was in the right fifth intercostal space in the mid-clavicular line. Left heart border corresponded to the apex, and the right heart border was substernal. And normal S1 and S2, normal S1 with normal S2 and normal respiratory split of S2 was heard, and there were no added sounds. So, final diagnosis, sir, was likely an acute coronary syndrome, probably drug-induced, and the patient was in normal sinus rhythm with no mechanical complications and not in heart failure.
This is the clinical diagnosis.
Yes, sir.
Not gone to the ECG yet.
Yes, sir.
So the risk factors.
In this patient, sir, the risk factor on clinical examination alone was the presence of visceral fat and obesity and hypertension with an elevated blood pressure.
Can
And-
overexertion cause an MI?
Yes, sir.
He's a bodybuilder.
Yes, sir.
What types of infarctions are expected, which is more likely to occur following a strenuous activity as compared to somebody who presents with MI without strenuous activity? What etiology you will specifically looking at? Very commonly asked clinical scenario, a young lady presents with retching, vomiting, abdominal pain, presents with ECG showing ST elevation, MI, likely diagnosis.
I didn't get the question, sir. Because of the hypertrophy in
No. So what kind of etiology of MI? So plaque can either rupture,
rupture.
it can either erode. Listen. Either it can rupture, either it can erode, or it can cause a spontaneous thrombosis, or there can be something which is more common in post-strain rather than rupture erosion.
Dissections or spontaneous
Yes, that's
coronary artery
spontaneous.
dissections.
That was the idea of asking you why that is more common. Again, so what are the risk factors of spontaneous coronary artery dissection causing a myocardial infarction?
Spontaneous coronary artery dissections are more common in female patients and more common in the peripartum age group, sir. So the
Correct.
risk,
Any other etiology underlying some disorder?
it can be associated with sir atherosclerosis per se also, and
Lipids actually don't give
Others.
anything else. Yeah.
use of certain drugs
Have
like
you have
cocaine.
you heard of fibromuscular dysplasia?
Yes, sir. Fibromuscular dysplasia is a risk factor for SCAD in females, sir.
That is one. And then,
Yes, that is.
Hormone replacement therapy is
then illegal drug use, like cocaine and all
cocaine.
that. That can cause that. Then you have already talked about the apartment time, and extreme stress can cause. Extreme physical exercise, or emotional stress can cause. Childbirth itself can cause recent childbirth. And typically, it is seen at the time of the term pregnancy. Interesting. Right. So in your examination, you said that there is no earlobe crease. So what is the relevance of earlobe crease?
So Frank sign was is traditionally associated with increased risk of atherosclerosis, coronary artery
What
disease.
exactly is this? Where is this earlobe crease?
So it's a diagonal crease
Yeah,
from
it's a
the
diagonal
tragus,
crease. Yeah,
from the tragus to the outer
yeah.
face of the lobule in the
So
inferior lobule.
classically, it is seen in which population?
Caucasians,
Right.
and it is associated with aging. And however, the evidence for its association has been questioned in different studies, and it is not very robust.
Absolutely.
It's known as the Frank sign. So it was first described by Frank, who
Yeah.
associated this with the presence of ASCVD.
The recent studies, they have given it up, actually. They have found
Exactly.
not a good association. What about xanthelisma?
So xanthelisma are more commonly seen in the inner surface of the medial surface of the eyelids.
Above the canthus, yeah. What does it indicate? If it is there, or how often it is there in a patient with coronary artery disease?
Indicates a dyslipidemia, but
Lipidemia in
sensitivity.
all patients.
No, sir, it's not very high. Sensitivity is not very high.
It is around 50% of the cases. It could be indicative of dyslipidemia.
Have you heard of Dutch lipid criteria, physical signs and symptoms?
Yes, sir.
What exactly? So in such patient, when you have talked about xanthelisma, you have talked about even tendon and palmar xanthomas and corneal arcus. What are you really thinking of? What he could be having underlying?
Familial hypercholesterolemia, sir, homozygous or hetero.
Exactly. Good. So do you know the scoring? How much scoring is for what? Just a rough idea.
There are two criteria, sir. One is the Dutch lipid criteria, and the second is the name criteria. I'm forgetting. So there's a score for LDL. There are LDL cutoffs. There's a score for gene positivity, and there is a score for physical findings on examination, which includes tendon xanthoma and palmar xanthomas.
Great. Good. So, basically, the Dutch lipid criteria is more of clinical, and you mark it accordingly with that. So, and if you're following that, then that can give you the diagnosis, the suggestive diagnosis. It is not 100% diagnostic. 100% diagnostic is the genetic test. So did you take a detailed family history in this patient?
Yes.
How did you take family history? What did you ask?
So first, I made a family tree about his parents, his sibling, and his grandparents, and of those relatives who had died, whether they had died of natural or unnatural causes, and whether the cause was determined conclusively to be of cardiac nature in any of the patients.
Good. Good. So you did talk of sudden cardiac death also.
Yes, sir.
Any unexplained deaths in the family?
So the patient's grandmother died around the age of 82 years of age, but
Oh, that is okay. That's
no premature deaths in the family.
go ahead, I think. Kindly.
So myocardial infarction with mitral regurgitation. Anterior MR, same intensity of MR, or inferior wall MR, which is more dangerous.
Sir, anterior MI with MR, sir.
And same about complete
The
heart block.
posterior,
Inferior-
the MR is more the posteromedial papillary muscle has a single blood supply as compared to the anterolateral papillary muscle, which is supplied both by the left anterior descending as well as the circumflex. So posteromedial is more likely to be involved in inferior wall MI.
So that's the whole story, It's the same intensity MR or same grade of complete heart, heart blocks would represent more muscle at geopardy or more muscle injured for an anterior wall MI to cause complete heart block rather than inferior wall. And that's why the bad prognosis. Right. How are Indians different from Caucasians for their prognosis or presentation for acute myocardial infarction?
Sir, the prognosis is relatively poorer and as compared to Caucasians. The age of onset is younger in younger patients.
A decade younger, more
Mhm.
likely to be multivessel, more likely to be CABG, smaller vessels in diameter, more likely to present with heart failure, repeated events, and early death. So this is I often tell. I remember Avinav telling you this even for the entrance viva. Remember this, it's true for Indians with heart failure, Indians with RST, Indians with ischemic heart disease. It's universally true. Any other drug that can cause MI?
Cocaine, sir, is very
Any other?
common. Even in susceptible populations, drugs like methamphetamines, ephedrine,
Uh-huh.
pseudoephedrine,
Any other therapeutic drug, not recreational drug? In oncology, which causes
donorubicin are
no,
more
that'll cause heart failure,
heart
which
failure.
causes myocardial infarction because of microvascular injury, rise in troponins.
Cisplatin, I'm not sure.
Correct.
Cisplatin.
Cisplatin, yeah, cisplatin can. That's correct. Right. So your diagnosis is ACH drug induced, normal sinus rhythm, no mechanical complication, not in heart failure. So you want to, how would you go ahead? So give me differential. I mean, this kind of a presentation need not always be an MI, right? That's not the first diagnosis. 60 minutes of angina, as Sir was saying. Anything else that can present with this kind of a symptom or presentation?
The second could be just a coronary vasospasm, which was transient due to the drug, which has now resolved.
60 minutes.
Little less likely because
Okay, let me put it the other way around. What are the differentials of troponin elevated and normal coronary?
it could be, sir, due to Takotsubo cardiomyopathy.
Very good. So that's one thing that you should know. A lot of patients can present with failure and angina without. Takotsu was one. Minoka. What is Minoka? Minoka is a broad term for the whole thing. So
Which
myocardial
includes
infarction are normal. So you should have talked. So bring out those terminologies so that you tell the examiner that you know the recent stuff, Minoka, Inoka, etc.
pulmonary embolism can also present, sir, with increased
Yes,
troponin.
pulmonary embolism, correct. HTM,
Sorry, sir.
PPH, pH crisis. You said
Yes,
pulmonary
sir.
embolism.
Yes, sir.
Srinivas, sir, any questions?
Fine, I think is going on well. Any other cause for the trope elevation but normal coronaries can happen in severe hypotension due to any cause, severe hypoxia. Hmm? All these things could predispose all
Myocarditis.
sepsis with all these scenarios where there is hypotension, hypoperfusion. There again, there could be pseudopositive trope elevation, the normal coronaries. Sometimes it may not be normal coronaries. It may be just to us, it may be normal coronaries on the epicardial angiogram, but the small vessel involvement, branch involvements, distal vessel involvements, it could also be there. Of course, they don't get into the definition of Minoka. Yeah.
Mm. And also, sometimes when there is pulmonary embolism and pericarditis, you can get a similar chest pain with a little elevation of troponin.
Yeah.
Okay, go ahead, Abhinav.
So, sir, this was the ECG at the presenting hospital. It is not very clear. This was done at the primary healthcare facility, which the patient had presented with immediately when he had the onset of the pain. And this was the ECG when he presented to us at our center after the pain had subsided a little, sir. This ECG is suggestive of normal sinus rhythm with normal axis and suggestive of ST elevation in leads V3, ST elevation and T inversions in lead V3 to V6, and very subtle elevation in lead 2 and 2, 3 and AVF also, sir.
Mm-hmm.
And however, as compared to the
Q waves.
there is evidence of, sir, Q waves in lead 3 and AVF, sir.
AVF and bit in the V6 also a little bit.
Yeah, absolutely. V5, V6 also.
And the R wave amplitude is however preserved. And this was the follow-up ECG, which was done 4 hours later after the first ECG, sir. The changes have settled, likely suggestive of self-recanalization of the artery, sir.
Why do you want to say self-recanalization? Why is it not an evolved MI?
Evolved MIs are less likely because there are no Q waves in the precordial leads, sir.
It is there, no? In the limb leads and the lateral
In
leads.
3 and AVF, sir. Yes.
Yeah, in 3 and AVF.
And V.
And with the STD changes also.
Yes.
Hmm?
Yes.
So little persistent ST in V6, V5. Okay. I mean, of course, there may be recanalization, but there is an element of infarct also.
Infarct.
Not always no infarct at all.
Yes. On blood investigation, he had a
In
elevated.
the first, can you just take back to the first ECG? What are the leads in which the elevations and all are maximum here?
In this, sir, the patient had maximum elevation in lead V2, V3, V2 to V6, sir,
2 to V6.
and also in AVL 1 and AVL also, sir,
ABL. Okay, okay.
which were not there in the second.
Later ECG, you're not seeing that.
Yes.
Okay.
In this, the elevation is not significant, sir, in 1 and AVL, sir.
So what are the differentials of ST elevation other than in acute myocardial infarction?
Sorry, sir, I didn't hear.
Differential diagnosis of ST elevation other than myocardial infarction.
It can be seen in Takotsubo cardiomyopathy also, sir. It can be seen in an LV aneurysm, which has been there for some time. So if associated with the Q wave and ST elevation.
Brugada?
Pericarditis, sir, Brugada syndrome or J point elevation may be seen in early repolarization syndrome also. or myocarditis can pericarditis, like pericarditis can have concave ST elevation.
So how benign is the early repolarization?
Sir, according to recent studies, early repolarization is not entirely benign. Patients who have repolarization, particularly also involving the inferior as well as the lateral leads, and early repolarization involving multiple leads may have idiopathic ventricular fibrillation and may also have short coupled VPCs. So it is not
How about
entirely,
Brugada? Brugada, how prevalent it is in our part of the world?
it is not very prevalent, sir.
1 in 500 is still, you'll call it prevalent, right? So compared to the rest of the world, of course, Southeast Asia is the most common area, but Indians also are at risk of Brugada. So most of them are hidden, right? You need to bring out. How do you bring that out?
We do provocation for Brugada by giving prokinamide, sir, or using ajmalin.
Azamalin is of course not available, so
Of
propanamide
flecainide provocation can also be
can
done.
also be done, right? Okay, so suppose this patient is received at your center. What's your strategy?
Uh,
Okay, can you tell me what is the total myocardium at Geopardy just by looking at the ECG?
Sir, a significant
Can you
amount,
localize the artery, number one, and can you tell what percentage of myocardium is at injury or at risk?
a a big chunk of myocardium is at in Geopardy, sir, because there's elevation in leads 1 and AVL also.
So you know any scoring system? That's what my question is.
I'm not aware of, sir.
Yeah, so there is a scoring system which ascribes the ST elevation and number of leads and adds also the Q wave. I'm forgetting the name of the system, and that tells you what percentage of myocardium is being correlated with nuclear scan. Also, mm, the uh, the other question that I asked you as to localizing, so that also you should know. So ideally, when you're asked a short case or a case of young CAD and you're shown the ECG, just like you read other ECGs in rheumatics, you should say this probably. So where is the probable occlusion in this case?
There's elevation in 1 and AVL also. So the left anterior descending proximal to the diagonal,
What about septal?
and the V1 is not significantly elevated, sir. So likely distal,
Likely,
sorry, sir,
likely, distal or
distal,
proximal or midway?
distal to the first septal and proximal to the first diagonal.
Very good. Suppose septal is involved, then what will be expected?
QRBB and
Okay, what else?
elevation in lead V1.
URBBB is usually proximal ostial, right?
Yes, sir.
So anything else? V1, were you looked for V1, right? Why did you look for V1?
Elevation in V1 is suggestive of
Right. What about if you have elevation in 2, 3, and AVF also apart from the current ST elevation in this patient?
It could be a wraparound LED which is supplying the
Very good.
influence also, sir. So the area
So that is
touch,
also called as type 3 or LED, wraparound LED, right? Or second cause?
it could be a CTO of the right coronary artery which was being supplied by a
Absolutely.
collateral.
Supplied by LED. Very good. Third,
Concomitant.
can it be double MI? It can be double MI, right? You
Yes,
can
sir.
have an MI of both LEDs. Sometimes some rarely can present with thrombus, which is usually a cardioembolic or even otherwise. Can have two lesions giving way because inflammation begets inflammation. One of the inflamed arteries gave you another plaque rupture, and then you got two double MIs. And of course, sometimes the other hypothesis was the direction of vector, which people said in a large wraparound LED proximal to the septal give rise to ST elevation. So septal involvement is there. So if S2-3 elevation is there, it's a wraparound LED. The lesion is obviously proximal to S1. Is it clear? Yeah. Yeah. Okay. Any other questions, sir? Majan, sir? Srinivas, sir? Ashwini Mehta, sir?
Fine, I think.
Yeah.
You can move
So
on.
I think we can move on for the sake of time. It's already 8:45.
Right. So, Abhinav, next.
Yes, sir. So we got his routine investigations done. Troponin was elevated and other parameters were within normal limits. He had raised AST and ALT levels, and his lipid profile was also deranged. Cholesterol was 300 with an HDL of 18.7 and LDL of 260, sir.
What about neutrophil lymphocyte ratio or lymphocyte monocyte ratio? Have you read papers on that?
Yes, sir. It is a
Prognostication.
marker of inflammation. So NLR is associated, increased NLR is associated with
More
EC.
inflammation, poorer prognosis. Correct. Okay. Next, go to echo. Yeah, go ahead.
The 2D echo was within normal limits by the time we did the echo, and the ejection fraction was normal, and there was no evidence of any valvular regurgitation. We got his coronary angiogram done when he presented to us, which was suggestive of a. This is the RF caudal view. It was done from the right radial root with the 5 French tiger catheter, which is suggestive of a floating thrombus in the proximal left anterior descending artery, as visible in the RF caudal view as well as in the iliocaudal view. So, however, the flow in the left circumflex was normal, and the flow in the left anterior descending was TIMI 3 flow, sir. And the right coronary artery was within normal limits, sir. We kept him on anticoagulation and after and DAPT with statins, and we did a check angiogram 4 days later. So there was the thrombus was partially resolved, sir. However, there was still some residual thrombus in the proximal LED. We took an OCT run also of the proximal LED. There was some
What is the outcome of erosion study?
Sir, according to the erosion study, if erosion is there, we can leave the patient without a stent also, as opposed to a plaque rupture.
For what outcome? What was the outcome? At what time? 6 months,
MACE,
1 year, 2 year, 3 year, 10 years, 20 years?
MACE at, I think, sir, 6 months. Not sure of the time duration. The major
I think it was
was
1 year. I'm not sure, but it was probably 1 year. So you can, and what percentage of patients were erosion in the erosion study?
erosion is more common in younger patients as compared to.
I think, to my knowledge, it was 1/3. So that's the percentage of patients they found to be plaque eroded. So all comers, OCT, erosions kept on, and other patients randomized, and that's how the trial design was. All right. Any other questions? I think that those are the clear. You did well. So tell me the.
Abhinav?
Sorry. Yes, sir.
Picture, Abhinav? What did OCT show in here? The thrombus definitely is there.
Thrombus and lipid plaques, sir, that's it. There was
No erosion.
No, sir, no erosion or rupture could be appreciated. However, it was done 4 to 5 days after the acute event.
So I would like to ask you one question. So you are aware of erosion study. So what exactly did it show? And how does it, in your case, what is the learning from that?
So the learning in this case would be that not all patients need to be stented, particularly young patients, and an OCT must be done in all patients, and we can leave behind an erosion without any metal on antiplatelets, dual antiplatelet therapy.
Yeah. So if you look at the erosion study, in fact, 3, which was done. So what it really looked at in patients of STEMI with early infarct artery patency, what they looked at was that when you do the OCT guidance compared with angiography guidance of reperfusion, there were two arms. OCT guided was associated with less stent implantation during the primary PCI. That was the main thing. And it did not change the outcomes at all. So these favorable results which were seen with OCT, it can help in optimizing the reperfusion strategy. So that is what the learning of your case, that in such a case, your reperfusion strategy can be optimized by OCT, and which can be there. Now, we still come back to the cause of myocardial infarction. And you did talk about some drug. So the patient was able to tell you what was this drug?
It was, sir, it was a sympathomimetic drug by the name of clenbuterol. It is like this salbutamol only. It is used for asthma in horses.
Beta 2 agonist, basically.
Yes, it's a beta agonist. Yes.
Beta agonist.
Beta 2 agonist drug.
It is
Which increases the heart rate and increases the metabolic rate. So they give in the gyms for the fat loss. Yeah.
Yes.
What are the other drugs which are given?
It increases the skeletal muscle blood flow. So we
Yes,
take
sir.
it as advantageous.
Yes, increases the exercise capacity and the endurance of the athlete, sir.
So how does it cause myocardial infarction?
By, sir, increasing the sympathetic surge and probably by causing vasospasm, or in patients who already have a fixed stenosis, by increasing the heart rate and the contractility due to the sympathetic surge, by increasing
So
the
this patient did not have any kind of stenosis. Did he have any
no,
stenosis?
no, sir, no.
So in this patient, this doesn't seem to be the likely mechanism. So how did it cause?
We are not very sure, sir, whether the drug was the immediate cause or what. Because the patient had palpitations and chest pain around 45 minutes after taking the drug. And he had even though some tachycardia was not documented because in any of the ECGs. However, he had elevated blood pressures.
So there is a possibility that this drug might not be associated or may be associated.
Yes.
But even then, the thrombotic mechanisms can also be triggered by the sympathetic surge.
Yes.
Right? And it can cause the formation, and there can be the endothelial erosions which can happen, and then that can cause a formation of a thrombus there due to thrombotic surge. That could be one of the mechanisms. Could it be coronary spasm contributing to it also? Is this beta agonist also known to cause coronary spasm?
Yes, sir. It is known to cause spasm also.
Yeah.
It is possible, sir. But there was definitive evidence of, sir, angiographic as well as OCT evidence of thrombus in the coronaries. So probably a component of both spasm was also there.
In the background of lipid plaques?
Lipid plaques were there, sir. He was obese and he had deranged lipid profiles also, sir. So probably multifactorial etiology of acute coronary.
So fine. So in such a young person in which you have a myocardial infarction, you talked about the deranged lipid profile. So what exactly, when you got his lipid profile tested, what were you looking at? What were the various parameters you were looking at, and why?
LDL, sir, is the most important risk factor. And this patient had an LDL of 260, sir. And his HDL was also less than 40, sir. He had an HDL of 18, sir. Triglycerides were in the normal range.
Okay. And what else in the lipid profile you look for in a young person?
Non-HDL cholesterol, sir.
Something else also. A young man coming, although he doesn't has a family history, but still in an extended lipid profile, you are looking for some lipoprotein small a. So you must look for that. Yeah. So as a routine, at least once in the lifetime, one must do an extended lipid profile because that remains forever like that. And the LP little a in any patient who is a young MI has to be seen. So what are the normal cutoffs and what level prescribes to the higher risk of getting ASCVD?
LP little a more than 50 is associated with, sir, high risk
Of
of ASCVD, sir.
and what else?
Also stroke, sir. Multi-vessel involvement like PAD
So
and
that is ASCVD.
yes, sir.
That you've already committed. ASCVD can be coronary artery disease, it can be cerebrovascular disease, it can be peripheral vascular disease. What else? Have you heard of aortic stenosis
Yes,
in patients?
yes, sir.
So what is the percentage of patients who have AS because of elevated LP little a?
It is it is being newly recognized, and
Yeah.
it's a relatively newer entity that in patients with AS.
Very good. Nice. So you are aware of this
Yes.
particular. So, it has been seen that patients who are above this 75th, more than the 100 milligram per deciliter, so they are more likely to have increased risk, 75th percentile, more than 75th percentile for the risk of aortic stenosis, LP little a of more than 100, and it has an incremental value more than 50. And as the value increases, the chances do increase. Right. So now, could you repeat the angiogram and the OCT of this patient later after a few weeks or months of follow-up? So that
Yes.
will give you a good idea.
Yes, sir.
Have you done it? When did this patient got discharged?
He
And
was
how is he
like-
doing in the follow-up?
He was admitted with us 2 weeks ago, sir.
Okay.
And he's asymptomatic and on double and DAPT with statin, sir.
Right. So I come back to your question of lipid profile, and you did find that this patient had hypercholesterolemia. So what else did you do? Did you advise something to this patient?
Statins were given, high dose statins were given, and a lipid profile is planned after, sir, 4 weeks. And
Okay.
we plan to add ezetimibe or bempedoic acid if the LDL is not in range, sir.
Both, or which one you like to give?
First ezetimibe and second bempedoic acid.
One thing I did ask you was, and I told you about the LP little a.
Mhm.
So in any patient, a young patient, you have found this, what else you'll be advising? Have you heard of something known as a cascade screening?
Yes, sir.
What is cascade screening and
Uh,
why?
We test the, sir, relatives of the first degree relatives of the patient for lipids, and if in cascade screening, you say if the patient himself has gene positive for familial hypercholesterolemia.
So any patient who has LDL of more than 190 itself gets a very high percentage point for a familial hypercholesterolemia, is a candidate, should be advised. In your patient, it was 280.
Yes, sir.
And I'm not sure you got LP little a done or not, but then if that was also high, that is again seen in familial hypercholesterolemia, especially in patients with young MI. So you have to advise them for the cascade screening
Yes.
also. Okay. And if possible, also the familial hypercholesterolemia genetic test, because then his risk persists lifelong.
Yes.
And you're not just treating him, you're also treating the whole family and society at large. Okay. Just proceed. Okay. So what was he discharged on? And what is your strategy?
He was discharged on a DAPT with high dose statin, 80 mg of atorvastatin, along with low dose of beta blockers, and
With DAPT.
with DAPT.
Which DAPT?
Aspirin and ticagrelor.
Okay.
He had been loaded with
What
ticagrelor.
else? What else did you give him?
We gave him, sir, in our practice, we also give 0.5 mg of colchicine, sir, if HSCRP is raised.
Colchicine is for recurrent events. Don't jump to colchicine.
Yeah.
Beta blockers, ACE, ARB,
Yeah. So where are the RAS
MRA.
blockers and the beta blockers? Yeah, exactly. Dr.
Yeah,
Kamal.
we gave him sir low dose of beta blockers.
So on what basis you gave that? What is the evidence?
So till 1 year post MI,
Yeah.
all patients decreases the risk of ventricular arrhythmias and remodeling also, sir.
Dr. Kamal, you were asking something. Please go ahead.
No, I was just saying the same thing what you asked, sir.
Okay.
Which is the
So
group?
beta blocker, you have positive data, you have negative data. We have some data now that says you can stop at 2 years.
After
Then you have data for
now
Comet CCS. Sorry?
the data now says that after 1 year of MI, there is no incremental benefit in continuing beta blockers for a longer period of time.
Which trial?
It was recently
So 3
presented.
trials published on this, 2 positive, 1 negative, and the confusion still
Extend,
exists.
I think
But
extend trial. Sure.
the only thing is that we surely know IV beta blockers don't do any beneficial benefit. So Comet CCS2 showed us that there's no benefit. Whatever benefits you get by reduction in font size is negated by worsening of heart failure and prolonged hospitalization or need of ventilatory care. So no IV beta blockers, oral beta blockers for 1 year, beyond 1 year, take your call. That would be the strategy.
And what about the ACE inhibitors?
Since he was a hypertensive also, sir, so
Right.
ACE inhibitors were given
No, irrespective of hypertension.
irrespective of hypertension.
You want to give, you don't want to give. Acute MI, EF of 55, post-lysis, post-recanalization.
Want to give, sir?
Trial. Most of the trials were with EF 40 or below. Air, save, right?
Beyond in normal ejection fraction, sir, the benefit of ACE inhibitor ARBs is not very.
So how long do you give? That was the question.
ACE inhibitors, beta blockers for
Yes.
1 year, sir, or routine.
No, ACE inhibitors. ACE or ARB. Normal LV versus not normal LV.
Not normal
LV
LV, sir, lifelong,
Correct.
and normal LV, I'm not very sure of.
So, yeah, so there is no clear-cut evidence, but then they should be considered because itself beta blockers, the ACE inhibitors
Negative
have
remodeling.
negative remodeling, and also they have although there is not much damage, but still negative remodeling can happen. And also they have a role in atherosclerotic prevention at various levels. So there is a reasonable evidence to suggest they should be given. Not a clear-cut evidence from trials with a normal ejection fraction, but anything less than 40% has to be. Okay.
So I think Dr. Abhinav did wonderfully well for a case of young CAD, and for the in the interest of time, I must thank all our experts and also Dr. Abhinav for a wonderful case presentation, so that we can move to our expert talk of the day, where approach to an Indian case of young CAD is what Dr. K. H. Srinivas is going to take us through. So over to you, Dr. Srinivas, sir. Sir is a senior faculty, and can you, Abhinav, stop sharing your slides so that sir can share the slides?
He has to stop sharing the slide.
Yeah. Abhinav?
Yes.
Yeah.
Okay.
Done.
To just trying to share. Are you seeing the slides?
Yes. So, sir, as you know, is professor and head of the Department of Cardiology at Sri Jayadeva Institute, one of the most premier institutes of our country, and one of the avid teachers, one who's taking the legacy forward of one of the prime institutes. Sir, thank you very much for firstly agreeing and then being a faculty and then taking us through very unusual topic. When I was discussing with him, he was a bit surprised on the topic, but he actually was more than happy to take it because I think this was a topic that's never been probably ever been covered in the PGT range so far by a faculty as per se. So over to you, sir.
Uh, Firstly, I would like to thank Dr. Kamal Sharma and the 3C team for this opportunity. Abhinav, you did a wonderful presentation. Your approach was quite good. Well, I mean, most of the things that I'm going to say now has already been discussed by Dr. Kamal during the things, and I mean, it will be just some of them. Majority of the things will be a recap of the same. Yeah, well, we all know, we just know the cutoff. For premature coronary artery disease, most of the guidelines take age less than 55 in men and less than 65 in women as for the definition of premature CAD. However, for the young CAD, the definition, the age cutoff is often taken as 40 to 45 years. That's when we call it as a young CAD. Well, these type of news items we keep seeing every day, and they again just go to convey to us that our society is seeing a lot of coronary artery disease in youngsters, and this is being further increased by early onset of diabetes and high blood pressure. Smoking as an habit in the teens and young adults is really taking a toll, and many celebrities have died young, many times due to the various stresses of life, and not taking care in the presence of family history, or due to the workout in the gyms, which we really don't know. Well, we are in for a lifestyle epidemic, with being the 10 biggest killers in India. The number one is the heart disease, and really it's a warning bell that all of us have to react. In fact, we have been talking about this for more than 2 decades, but still each day we keep seeing more and more people, young people, having this disease. All the news channels keep on covering this topic time and again. This NDTV data clearly summarizes the problem of young CAD in our country. So nearly the age of the first attack has compared to the Westerners and the Caucasians in Indians has come down by nearly 10 to 20 years. And the first heart attack among Indian men occurs in 50% of the cases. In 50% of the first heart attacks are in people less than 50 years, and really 25% of them are in men under the age of 40 years. In fact, the coronary artery disease is cutting across the socioeconomic barriers. The rich and the poor are getting this problem equally, and women are catching up, and even the urban and the rural divide is getting blurred. And in fact, during the COVID pandemic, in fact, it has thrown a disturbing finding that there is increased incidence of heart attacks as one of its main presentation, where many etiological things were considered. As already highlighted earlier during the discussion of the case, Indians have Asians, South Asians, and especially Indians have early onset of coronary artery disease compared to the Caucasians. The many causes of myocardial infarction without coronary atherosclerosis, some of them we already touched upon. If you can just go through, I think we have to keep in mind the possibility of arteritis, especially the Takayasu arthritis. We still keep seeing Takayasu arthritis with osteal involvement of the coronaries as a cause of MI. Once in a year, definitely we encounter these cases even today in our practice. And the children who develop Kawasaki disease in childhood are at risk of developing coronary artery aneurysms and stenosis. And as already discussed, spontaneous coronary artery dissection is common in young women, and more so in the peripartum period. And women who are taking oral contraceptives and who also are smokers are very much prone for myocardial infarction. And the role of, at times, it can be due to trauma to the chest, and there can be predisposition by the radiotherapy, which is given for the treatment in oncology, and a lot of metabolic diseases with storage disorders can also predispose to myocardial infarctions. And as already discussed, spasm of coronary arteries, the prinzmetal angina can lead to myocardial infarction. Dissection of the aorta, which we already considered, can extend to coronaries and cause the dissection. So apart from the routine coronary atherosclerosis, in fact, when you do an angiogram for a acute coronary syndrome in nearly 12% of the patients, the coronaries could be anatomically normal. Some of them could be due to coronary emboli, which are lysed already, or the vessels may be too small to be visualized, or there may be thrombophilic disorders like antiphospholipid syndrome or protein CRS deficiency very rarely, or factor factor V Leiden, which can predispose to thrombosis, atherothrombosis. Well, as we already discussed, even with normal countries, whenever there is hypoxia with augmented oxygen demand, or there is hypertension secondary to sepsis or blood loss, or some of the pharmacological agents, as in the this case where the beta 2 agonist was the culprit, and of course anatomical variations with congenital coronary arteries going in between the great arteries can have a predisposition for an event. Well, the risk factors we have already discussed, the genetic factors. They have been keen the area of interest for many researchers. However, we have not come to any single gene which can be blamed, and as of now, we are not in any position to target the gene therapy for the prevention of premature coronary artery disease. This was already alluded to by Dr. Kamal Sharma during his initial interaction. So psychological factors are important, absence of regular physical activity, and of course, poor daily consumption of fruits and vegetables is one of the risk factors that we see in the Asian and the Indian population. So, as already said, these traditional risk factors were validated by Intrahart study, and they account for nearly 90% of the population attributable risk. And among these, the smoking, the high waist hip ratio, and the high ApoB and ApoA1 levels ratio is one of the risk factor for acute MI in South Asians and Indians. Smoking is the most important factor in a premature coronary artery disease, and it has been noted in nearly 60 to 90% of the young patients presenting with MI, compared to 20 to 50% of the patients in older age group. And as we already discussed during the discussion, the family history is present in nearly 40 to 60% of the young patients with coronary artery disease. If you just try to ask the patient about anybody in the family having the disease, you may get this history, positive history, in nearly 40 to 60% of the cases. And we have to be really serious in these scenarios. In fact, once we identify a premature coronary artery disease, we have to, as already suggested, we have to go for evaluation of the younger people in the family for the various risk factors for premature coronary artery disease. In fact, the offsprings of patients with premature coronary artery disease are more likely to have coronary risk factors than those without such a family history. So one has to really look at the body weight, the higher serum levels of cholesterol, increased glucose levels, and hyperinsulinemia in these situations, which could predispose to endothelial dysfunction, and even there could be increased carotid artery intima media thickness in the offsprings. So one has to really monitor the offsprings for preventive care to be instituted early in their life. And the association between family history and premature CAT can be due to both genetic and environmental factors. This also should be kept in mind. In fact, this is one publication from our institute wherein we compared the lipid indices in children of patients with and without premature coronary artery disease. The 190 patients of 190 children of PCAT patients were compared with 190 healthy children of healthy adults. So we found that there was a higher association of dyslipidemia when compared to the controls, with conventional lipids and lipoprotein A were high, and the ApoA1 levels were low in the study group compared to the controls. Again, highlighting that we should always keep a watch on the offsprings of the PCAT patients so that we can guide them for better life in later part of their life. Well, the Indian dyslipidemia, the premature younger patients who develop coronary artery disease in India, they often have lower mean HDL and higher serum triglycerides. However, it was not so in the case that we discussed. And again, hypertriglyceridemia is an important risk factor which is associated with glucose intolerance, and it has a predominance of small atherogenic LDL particles, which predisposes to atherosclerosis and atherothrombosis. These traditional risk factors, diabetes and hypertension, they are compared to the elder individuals. In the young, they are less prevalent. However, though of late, they're also catching up in having these risk factors as the causative or the increase in more number of cases. Obesity, especially the abdominal obesity with increased waist-hip ratio, is an independent risk factor for coronary atherosclerosis, at least in young males. Very rarely, paradoxical embolism could be a cause for a myocardial infarction in younger patients. A good echocardiographer could give us a clue to look for this entity. Well, the frequent cocaine abuse is one of the important things which could account for nearly 25% of the non-fatal MIs in the young. Smoking marijuana may trigger a rare event of an MI. Well, these are the other emerging risk factors, which we already discussed. Some of them, the lipoproteinuria has already been discussed extensively. And the one other important factor that I would like to stress about is the environmental pollution. This is one thing which is really increasingly affecting the young people in the overcrowded metros. In fact, in our city, we conducted a study in the traffic police. So who are almost always standing in the traffic. We found that a lot of them had quite a lot of risk factors, and this stress test positivity was more common, and many of them we had to really subject them to angiographic evaluation and treat them before they develop the events. So we have to look at the environmental pollution, which can be a trigger for a premature coronary artery disease, as most of the youngsters are moving around in the cities, so they are more likely to have a problem there. So this is one of the epidemiological studies. I mean, the review article by Dr. Dalal et al. Again highlights what all we discussed till now. The analysis of the intra data in the South Asians revealed an acute MI prevalence of nearly 12% in India in patients aged below 40 years. And in the Kerala ICS registry of around 26,000 patients, the nearly 22% of the patients were below the age of 50 years. And in fact, the most important risk factors there were apart from diabetes and hypertension, it was the smoking, which was in around 34% of the individuals, which was the most important risk factors predisposing these youngsters. I'll not go in the Delhi, the number of active years lost in young population. It's the maximum in Southeast Asia compared to the other countries. In fact, if you look at this, you can see that nearly 30% of the cardiovascular deaths occur in less than people who are under the age of 60 years. That's the problem of the high premature, the CVD mortality in India. Only 30% of the deaths occur in people aged less than 60 years. This is a million death study report submitted to the Government of India by Ministry of Health in the year 2012. CADI registry by Iyengar et al. Analyzed the premature coronary disease in India. Here, of course, the definition of young CAD was as per usual, as per the guidelines, that is men below 55 and women above 65. The highlight was the family history of CAD was present in nearly 50% of the patients. Only 1.3% of them had possible familial hypercholesterolemia. Again, indicating since the premature CAD is a major problem in our country, it is necessary that we look at the cascade screening and try to identify more familial hyperlipidemia patients so that we can at least treat the heterogeneous hyperlipidemia cases early to prevent coronary ASCVD development. Well, as I was already telling, in our PCAD, premature coronary artery disease registry in our institute, we tried to see whether there is any difference in the rural youth. So the profile of CAD in rural youth who are under the age of 35 years, what we found was conventional risk factors such as smoking, low HDL, and abdominal obesity play a major role in the causation of premature CAD among the rural youth as much as in the urban youth. Thrombotic milieu in the coronary arteries was commonly noted in coronary angiograms. Nearly 40% of the patients had recanalized, non-obstructive, thrombotic, or normal coronaries when the angiogram was done. Nearly 60% of them were smokers. So smoking is a habit which is really taking a toll on our youth. Well, coming to the clinical manifestations, it is often in a young cat, the effort angina or stable angina is little less prevalent compared to the elderly people with angina. And they are often present with ACS. Nearly around 80% of them present with acute coronary syndromes. And coming to the disease severity in the younger patients are more likely to have normal coronaries or have insignificant disease with mild luminal irregularities. Single vessel disease is more common than do the older patients. And this is a analysis that we did in the year 2016-17, where 300 patients with STEMI who were less than 45 years, we looked at the risk factors, clinical presentation, angiographic profile, and the short-term prognosis. We see here the smoking was the most glaring risk factor. It was there in around 60% of the individuals. And coming to the number of the LAD involvement causing antral MI was the commonest presentation. The single vessel disease was in 46% of the individuals, while the normal coronaries or insignificant disease was in around 35%. 19% of them had left main and multivessel disease. So nearly 19% of them had multivessel disease and left main involvement as well. Well, this is another study from India, where in the angiographic profile and the treatment outcome of CAD in younger individuals who are aged less than 45 years was analyzed. And here, when they analyzed the type of the lesion complexity and compared it with various factors, they found that the commonest was the type 1 CAD. That's the majority of the people had the type 1 CAD. That is a single segment discrete lesion. And what is important to see here is the lipoprotein A levels were significantly high in those with complex lesions. There's nearly 70% of the LPA level was 70 milligram percent compared to around 30 in the type 1 and type 2 CAD. That means the LPA had a big role in the young MIs, that's what it says. And tobacco use was quite common, especially it was associated with more complex lesions. So nearly in type 2 CAD and type 3 CAD, nearly 70 to 80% were smokers. Well, they're highlighting the importance of educating them about this smoking and its problems. And as we saw in the previous case, we can see that the thrombus, when we take young people who come present, we come with an acute MI for angiogram to do a primary, often we end up seeing heavy thrombus burden, and we are in a dilemma what to do. Well, if there is an ongoing pain, as we all know that if there is an occlusion and an ongoing pain, everybody will pass a wire, and then if there's an ongoing pain, we will have to do, we should be knowing the thrombus aspiration techniques. That is one. And if there is large thrombus burden and a TIMI3 flow with a not so significant lesion, one can always consider intracoronary thrombolysis. We do this often. We use intracoronary tenective plays. We should always be ready to use intracoronary tenecteplase and follow it and give a follow-up dose subsequently, so that we can have a better resolution of thrombus from the coronary tree and have lesser in-hospital recurrences, and we can avoid stenting in many cases, as you can see in this case. And of course, there has been increasing use of OCT and imaging of late to identify distinguishing erosions from plaque ruptures, so that one can decide about whether to stent or not to stent. You can always do a follow-up study and guide the therapy accordingly. And it's often noted that the South Asians have more proximal LAD involvement compared to the Caucasians. So also the two-vessel disease and three-vessel disease, there is a multi-vessel disease is more common in young cats from the South Asian group, as seen in these charts. Well, as I already said, the South Asians have smaller proximal LED lumen diameters. So again, so one has to be alert to this possibility and um, assess the coronary arteries after giving the nitroglycerin, because sometimes it may be the acute MI scenario which is making them look small. So give good amount of nitroglycerin if the situation permits, and then assess the size properly before going on with the intervention. In fact, the similar phenotypic uniqueness of the South Asian cat was highlighted by Dr. Kaul et al. That's the premature atherosclerosis is common, the arteries are smaller, and the South Asians had more TVD compared to Caucasians, and more diffuse disease, more distal disease. And this we are seeing time and again in our population, that the disease severity is increasing, and we are seeing more diffuse disease, especially with the incidence of diabetes increasing in younger individuals. We are having this increase in diffuse and distal disease during the angiogram that we are seeing nowadays, making our decision during the therapeutic decisions that much complicated. So, well, coming to the long-term evaluation, this is we can say that we have to consider guiding the people to quit smoking, and we should always keep in mind the family history of CAD or hyperlipidemia, so that we can guide the patients properly. In fact, in this long-term evaluation study, we can see that whosoever were smokers and who had family history of CAD or hyperlipidemia, the nearly 1/3 of the patients had recurrent myocardial major adverse coronary events, and of these 36% of them had at least second recurrence. This is despite initial prescription of aspirin and statin. So one should always keep this in mind, especially if they continue to smoke and if they are not taken care of their hyperlipidemia well. There are many clinical factors that are associated with the recurrence. That's the most common thing is the insufficient control of conventional risk factors like diabetes, hypertension, and smoking. And when they have multivessel disease, they have more chances. Yeah, I'll be concluding in a while. Yeah. So smoking was the strongest modifiable factor for recurrent MACE. So hence we need to stress on this a lot. Here, the FEG data wherein the appraisal of risk factors in young ischemic patients justifying aggressive intervention in patients with premature coronary disease. Nearly 48% of the patients with first recurrence were not taking high intensity statin. That means the doctor is not doing enough to impress upon them the need to take the proper dosage, and so nearly around 7% of them were not taking statin at all. It may be due to ignorance, illiteracy, and other factors as well. So whenever we are not on target, we should consider adding other lipid modifying drugs to the statin, especially ezetimibe is quite economical and should be considered to reach the target LDL concentrations. And of late, even the bempedoic acid is available at a lesser price in India. We could probably use it in people where we find it difficult to reach the target. PCSK9 inhibitors, they are at present quite expensive, may not be generally used in the public sector scenarios, but however, many corporate hospital scenarios, one can also consider using PCSK9 inhibitors to get to target recommended. So again, secondly, because the recurrent rates are so high, even more efforts need to be directed towards preventing the development of CAD in the first place through primordial and primary prevention efforts, which every one of us should spend some time on educating the patient and educating the family to break the cycle of CAD in the young adults by using a multi-pronged approach, as we can see in this pyramid. We have to, firstly, we have to intensify the secondary prevention with proper acute care management, followed by secondary prevention measures that we take. Then we should recognize the young adults at risk. That is, we should recognize the red flags, those who have high risk plaque, those who have obstructive CAD in multiple vessels, those who have uncontrolled diabetes, those who continue to smoke, and who have high risk ethnicity in the family history, or the severe hyperlipidemia, as in the case of today's presentation, and especially those who have high LPA levels. These are the subsets we should recognize and target them for aggressive treatment. Should generally in the at the society level, we should educate them for healthy lifestyle, tackling the social determinants of health, trying to educate them to have good dietary practices and quit smoking, and take care of the diabetes well. In fact, the policy measures to ban tobacco could be useful, and restrict the access to retail alcohol, raise taxes on alcohol, reduce the salt intake and salt content of the food, try to replace trans fat in food with polyunsaturated fat, and promote public awareness about diet and physical activity by using the media to the maximum. So, well, these are some of the challenges that we are having in India. We have to focus on the premature CVD, and we have to really do our best to prevent it. We have to consider the regional variations, the health system challenges, the lack of access, the cost of care, out-of-pocket expenditures, and the lack of information. All these things we should keep in mind. Always remember to screen the children of premature CAD patients for dyslipidemia and diabetes. Encourage them to have the healthy lifestyle. The time-sensitive STEMI care approach is important. When we cannot take PAMIA to all the patients, we at least could quickly lyse them. This is more important in the primary care setup or in the villages. We should not always deny the lysis just because they are not willing or not, they are not able to get a primary angioplasty done. We should quickly lyse them, because most of these young patients with coronary artery disease have large chances of having large thrombus, and they could well respond well if we lyse on time, and we can always have the pharmacoinvasive approach later to settle the things that are not settled yet. And secondary prevention strict targets could be achieved using statins, ezetimibe, bempedoic acid, or PCSK9 inhibitors, depending on the extent of control required. This, I think, I'll conclude. Thank you very much for your patient hearing. Thanks, Dr. Kamal Sharma, and thank the 3C group for this opportunity. Thanks a lot.
Thank you, Dr. Srinivas. Wonderful talk and absolutely comprehensive with the perspective of young cat. So with this talk, we are already running short of time, so I'll invite now my friends from Delhi, Dr. Ashwini Kumar, Dr. Ashwini Mehta for his talk, and he's going to talk about, are we done with aspirin type of a topic, which is, can we choose a single antiplatelet? I think this topic is going to cover us for across the spectrum of managing dual antiplatelet versus single antiplatelet strategy in patients with ACS. So over to you, Dr. Ashwini Mehta.
So, Dr. Kamal, at the outset, let me ask you, that was supposed to finish, I think, at 9:30. So should I present or not? Because it's already 9:33.
No, you go ahead, please. There's no problem. Please go ahead. Please go ahead.
Okay. So I am going to be very quick and fast. And so just to highlight, we've been talking about the young MI, and like in this patient, we used ticagrelor. And today, the challenge is that on one hand, we have risk of thrombosis, and on the other hand, we have the risk of bleeding. To a large extent, with these good drugs which are there, the risk of thrombosis has been taken care of. And what really remains is the risk of bleeding. So in patients of ACS, they have a whole continuum of risk. They have a low risk of bleeding, increased and a very high risk. And that depends, what are the risk factors which are associated. And there are certain risk factors which are associated with increased risk of bleeding after PCI. One of them being the age, more than 75 years, another being the renal disease, liver disease, malignancies, anemia, low platelet count, and bleeding diastasis, oral anticoagulants, NSAIDs, steroids, planned surgery, so on and so forth. But what we know that up to 40% of patients undergoing PCI in routine clinical practice are those who are having a high bleeding risk. And we need to have strategies in place to have benefit of patients all along the spectrum of the bleeding risk, and particularly those who have more than one clinical characteristic, which I just talked about, associated with the increased bleeding risk. And this is the famous study done by Bunaka, and which identified the two easy spot predictors of major bleeding. And this, I think, we must keep in mind. So in Pegasus TIMI 54 study, two independent predictors of major bleeding were found. One is the history of spontaneous bleeding requiring hospitalization, and the another low baseline hemoglobin. So these two are big risk factors which predict the bleeding, and these fall in patients. Any patients having any of these would be classifying itself in a high bleeding risk. All others can be put in a low bleeding risk. So it's a very simplified kind of a thing. So what are the options today available to reduce the bleeding risk without increasing the ischemic risk in patients with ACS? So we all know that DAPT is the way forward when we treat such patients, but we can think of DAPT de-escalation to reduce the bleeding risk. And the ideal strategy should reduce the bleeding risk without increasing the ischemic events. So what are the various strategies which can be followed? With a short-term DAPT, which can be given with a potent P2Y12 inhibitor. So one could be using ASA plus clopidogrel, another could be stopping ASA, continuing with the clopidogrel monotherapy, or one could be just continuing the ASA monotherapy or ticagrelor monotherapy. So each one of them have their own merits and demerits. We'll be looking at each one of them, and we'll be also looking at the scientific evidence which is there. So let's look at the strategy number one, which is the ASA plus decreased P2Y12 inhibition. So one famous study, the Talos AMI study, where the de-escalation was done to clopidogrel DAPT versus continuing the ticagrelor DAPT. And what it really showed was, as you can see here, that the cumulative incidence risk which was seen, which is NACE at 12 months. Now, if you really look, the cumulative incidence in changed DAPT was 4.6, and whereas in the unchanged DAPT, it was 8.2. It was an open label study, and what it showed was that if you look, however, at the plateau, it demonstrated a ischemic benefit of continuing ticagrelor versus the clopidogrel, and this is from the Plato study. We also have another study by the name Host-Reduced Polytech ACS, where the de-escalated dose of prasugrel DAPT versus a conventional dose of prasugrel was done. And here again, you do see that de-escalation of prasugrel dose after 1 month of conventional DAPT was non-inferior to continuing the conventional dose of prasugrel. And this was done in the East Asian population, but this trial excluded patients who had a body weight less than 60 kgs, age more than 75 years, and history of previous stroke. The another strategy could be de-escalation to the aspirin monotherapy. And we have 3 studies which are there: the SMART date, the DAPT STEMI, and the reduce ACS. Multi-center study, the randomized open label studies, and which have shown that ASA monotherapy after 6 months, the SMART date, was non-inferior to more than 12 months of DAPT at 18 months, but showed a significantly higher rate of myocardial infarction and no significant difference in the bleeding events. Then we have the DAPT STEMI. What it showed was that the aspirin monotherapy after 6 months of DAPT was non-inferior to 12 months of DAPT at the 18 months. There was no significant difference in MI or bleeding events. This was a small study, 870 patients versus the SMART date, which was a larger study. And then we had another reduce ACS, where again, it showed that there were numerically higher rate of MACE when ACE monotherapy was continued. So typically, I think this strategy doesn't really work. There are a number of limitations. These are in detail. I'd not like to go in detail, but then let's come to the de-escalation to clopidogrel monotherapy. Stop DAP2 ACS was a de-escalation from short-term DAPs to clopidogrel monotherapy, but it failed to meet the non-inferiority versus the 12-month DAPT. So this also did not show any evidence of benefit. So what we are left with is a de-escalation to ticagrelor monotherapy, and let's look at the evidence. So first, let's look at the rationale. We know that the ASA monotherapy after 6 months of DAPT was non-inferior to more than 12 months of DAPT at 18 months, but did show a significant higher rate of MI, and the clopidogrel monotherapy following 1 month of DAPT failed to meet the non-inferiority to 12 months of clopidogrel DAPT, and when both ischemic and bleeding events were looked at. So a new study was designed, which was the Twilight. And interestingly, this had ticagrelor ASA in the beginning, and at 3 months, there were 2 arms. One was DAPT, and the another was ticagrelor monotherapy. And various endpoints were looked at. And if you look here at the endpoints, this is the bleeding, BARC type 2, 3, or 5 bleeding. With monotherapy, it was significantly less than the ticagrelor dual antiplatelet therapy, which was continued, but it did not come at the cost of increase in the endpoints of death, MI, or stroke. So the benefit came, and the benefit was largely because of less amount of bleeding. So this one strategy, I think, is wonderful, especially in patients who are at a high bleeding risk, and also patients, who are at a high ischemic risk, as you see in this subgroup analysis. In this subgroup analysis, again, the similar benefit was seen with reduction in the bleeding. And if you look at the subgroup analysis of patients with high bleeding risk, it showed that in patients with high bleeding risk who tolerated 3 months of dual DAP, ticagrelor monotherapy at 1 year was significantly better as far as bleeding events is concerned. And same, that it did not show any increase in the ischemic events, whereby it was protective, as protective as the another. Then we have TICO study, which was done from the Korea in patients of ACS. And in this study, again, the same endpoints were there, MACE at 12 months of index events. So what exactly is MACE? It is MACE plus the TIMI major bleeding, and the secondary each individual component of primary endpoint was also looked at. So what it showed was that ticagrelor monotherapy following 3 months of DAPT resulted in significant 2% of absolute risk reduction in composite endpoint of 1 year MACE with ticagrelor DAPT. in patients of ACS treated with tests. So this again showed the benefit of just continuing the ticagrelor beyond 3 months. Then we have another TPAS, a prospective randomized multicenter trial in Korea, where the aspirin was discontinued after a month, and then the median in this study was just 16 days. So very early discontinuation of aspirin. And in my own experience, I've had patients who have bled, who have had very low platelets, first week after stenting, or maybe just on third, fourth day. And up till now, whenever we have stopped aspirin, we've been lucky. We have not had any more events. And similarly, in the CPAS, what you can see here, that there was a 46% reduction in NACE with ticagrelor monotherapy after 1 month of DAPT, which is quite significant. And if you look here at the 12 months clinical outcome, the hazard ratio is 0.54. And 1 month landmark analysis, again, the hazard ratio is 0.48, which shows significant benefit. And most of it is coming with reduction in the major bleeding, and the risk of death, MI, stent thrombosis, or stroke is not there. So what it concluded was that you can even use ultra short DAPT, maybe less than 1 month, in patients, certain category of patients. And in this particular study, the ultra thin biodegradable polymer cerebral limus eluting stents for ACS was used. And it did not come at increased cost of ischemic events. And this study provides the evidence of stopping aspirin within first month of implantation of DES with ticagrelor monotherapy as a reasonable alternative, especially in those patients who are at a high risk. Then we have the master DAPT study. Now, this trial again confirms the utility of antiplatelet monotherapy after short-term DAPT as a bleeding mitigation strategy, but does not provide any comparison of the individual agents. We have another study, the Panther extended P2Y12 monotherapy. And according to this study, the available randomized evidence, the long-term P2Y12 inhibitor monotherapy may be warranted instead of long-term aspirin monotherapy for secondary prevention of patients with coronary artery disease. And mind you, in this study, the median duration of treatment was much beyond 12 months. It was 557 days. So in fact, you can continue, as you can see here, you can continue with the P2Y12 inhibitors versus aspirin. And you can see that the here in the curve, the median duration, and it did not show any kind of issues. So what are the options available today to reduce bleeding risk without compromising the ischemic risk in patients with ACS? The ideal DAPT de-escalation strategy should reduce the bleeding risk without increasing ischemic risk. So we'll revisit these strategies. First one I talked about was ASA plus decreased P2Y12 inhibition, bleeding events versus the ischemic events. We have well-designed RCT to look at the ischemic events, but these studies were not powered really to look for the bleeding events, and there was no change. The ASA monotherapy again did not show any change in the bleeding events. Clopidogrel monotherapy almost balanced that, and ticagrelor showed no change in the ischemic events, but less bleeding events, whereby showing a overall superiority. Now, this seems to be the most plausible therapy, and I think as we are learning more and more, many of us are evolving and de-escalating it much earlier. So this short-term ticagrelor DAPT followed by a ticagrelor monotherapy seems to be one of the preferred strategy in patients of ACS with increased bleeding risk. And the de-escalation can be done. The de-escalation to potent P12Y12 inhibitor to clopidogrel DAPT is not uniformly recommended in clinical practice guidelines. Studies evaluating the de-escalation to SA alone, clopidogrel monotherapy, or prasugrel monotherapy have multiple limitations. There is evidence of short-term ticagrelor DAPT with de-escalation in the number of trials I've shown. And it does offer a best solution, in fact, as of now, for reducing the bleeding risk without compromising on the ischemic risk in patients of ACS. Thank you so much for your kind attention.
Wonderful talk, sir, and it's very comprehensive to the point. You mentioned as to which drug to use, when to use, and what's the science behind single drug use. And I think it's pretty much the bad guy of bleeding is
Yeah.
aspirin, not the P2Y12 that very often we were thinking to be, because it's more potent, it's more likely to bleed more. But it's actually more likely to come from aspirin, and the benefits may persist with P2Y12 inhibitors. Was I audible?
Yes, yes, wonderful.
Yeah.
You concluded it
Thank you
nicely.
very much, sir.
Hmm.
Thank you. Thank you very much, sir. So, Dr. Majan, sir, any other comments?
Excellent
Majan,
talk.
sir?
And ultimately, the most important thing we have to take from this is that all these trials are done with some ultra thin stains and some stains with the specific polymers. So we cannot use it randomizely to everything which is available in our market. So we have to strategy the patient depending upon the total length of stain, total diameter of the stain which is used, and any specific like left main or bifurcation or something like that. And there is another one strategy for patients with a multivascular involvement is de-escalation. Specifically after 1 year, one can go with a low dose aspirin along with the rivaroxaban, that to low dose, that is a compass regime. But yes, the most important thing is that low dose ticagrelor de-escalation is one of the best strategy, which is the safest strategy for the treatment of acute coronary syndrome treated with interventions.
Yeah, Dr. Mahajan, I'd like to make a point, little small point here. So one of the studies used ultra-thin stent with the biodegradable, in which, the aspirin was interrupted within a month. But other studies did not had ultra-thin stent struts. So in fact, this strategy seems to be working in most of the patients in the present day, the newer generation DES, which we are using.
Yeah, whenever we are planning for elective PCI, one should make it a habit to get the bleeding risk done.
Right.
Often we miss out on that, and then if we have high bleeding risk, we should choose the ultra thin struts so that if required, we can always get rid of the dual antiplatelet therapy.
Yeah, I think master DAPT and stop DAPT both have shown the point that you're trying to bring out, especially patient who's planned for some other surgery in near future, which was
Correct.
one of the reasons why we were desisted to do PTC, and instead patient ended on CABG side. I think that's changing now with the new evidence, and new trust emerging.
Yeah,
So thank you very much. Thank you. Thank you, Srinivasa. It was wonderful to connect. Looking forward to have you again. And
Thank
so also Dr. Ashwini Mehta. And fast final words from Dr. Jemajan, my colleague and my senior and my dear friend. Majan, sir.
Thank you. It was a very wonderful.
Thank you, Srinivasa. It was wonderful to connect. Looking forward to have you again. And
Thank
so also Dr. Ashwini Mehta. And fast final words from Dr. Jemajan, my colleague and my senior and my dear friend. Majan, sir.
Thank you. It was a very excellent topic which was discussed, and it is one of. Thank you. It was a very wonderful.
Thank you, Srinivasa. It was wonderful to connect. Looking forward to have you again. And so also Dr. Ashwini Mehta. And fast final words from Dr. Jemajan, my colleague and my senior. So there is some echo in the system.
Thank you. It was a very excellent topic which was discussed, and it is one of. Thank you. It was a very wonderful.
Thank you, Srinivas sir. It was wonderful to connect. Looking forward to have you
Okay,
again
so good night,
in
everyone.
terms
Thank
of
you. Bye
Lakshmani
bye.
Mata.
And we look
And
forward to have you for the
first
next
final
session,
words from Dr. Jamaluddin,
may,
my
which
colleague
is
and my
scheduled
senior.
next
There is
week,
some
7,
echo in the
which will happen
Thank
on
you. It
9th
was a
December
very excellent
2024.
topic which
And
was
that's when
discussed,
we will
and it
catch
is
up
one of.
you
Thank you. It
again.
was a
And
very
thank you
wonderful.
for
Thank you,
my
Srinivas
academic
sir. It was wonderful
partner,
to connect.
Astra
Looking
Nirvana
forward to
and
have you
Okay, so
Association
again
of
good night,
in
Clinical
everyone.
terms of
Thank you.
Lakshmani
Bye bye.
Mata.
Clinical
We look
Medicine.
forward to
Thank
have
you.
you
Bye
for
bye.
the first final words from Dr.
May,
Jamaluddin, my
which
colleague
is
and my senior.
scheduled